if they're using meth or stimulants like cocaine, if they have a family history of paternal history. If their father was an alcoholic, it's interesting, they're going to have a worse withdrawal. The symptoms of benzo withdrawal are these: anxiety, insomnia, restlessness, agitation. They'll be pacing up and down the hall. They'll be very nervous, irritable, twitching, tremor, perception of movement, increased sensitivity to sound and light, confusion, visual blurring, emotional lability, cramping of fingers and toes, muscle spasms, nausea and anorexia, tachycardia is fast heartbeating. Rarely you might see seizures, except Ambien and Xanax can cause seizures. They'll get delirium and psychosis rarely. And then they have protracted benzo withdrawal. It occurs in 10 to 15% of people. This is people that you get them off the benzo, but they still have symptoms later on. It's unpredictable, may last up to a year, and they'll get anxiety, insomnia, tremor, and hypersensitivity. So how do we treat benzo withdrawal? Well, you can do it outpatient or inpatient. Outpatients take a motivated patient. It takes a reliable patient. They have to be on no drugs and no alcohol. And you can do it by tapering. You can take the benzo they're on. You can take somebody that's on Klonopin 3 milligrams a day, have them go to 2.5 for a month, have them go to 2 for a month, 1.5 for a month. Taper them down that way. Or you can substitute a benzo by giving him Valium. This is called the Ashton method, named after a doctor in England. This is giving Valium instead of the benzo and then tapering the Valium. 10 milligrams of Valium is equivalent to 0.5 milligram of Klonopin, 1 milligram of Xanax, and 2 milligrams of Ativan. Again, you got to go very slow with slow follow-up. The third way to get people off is to give them phenobarbital. This is the best method. This is the one we use for anybody that's on a significant amount of benzos. This is for our inpatients. Occasionally I'll use this as an outpatient. I will continue it as an outpatient, keep seeing them on after that, but we begin it as an inpatient down on 3A. And this is the treatment of choice. Phenobarbital acts as an agonist at the GABA receptor. It stimulates the gamma receptor and slows down that withdrawal. It's got a very long half-life. It's well tolerated, a few side effects, and there's very minimal withdrawal when you stop taking the phenobarbital. 30 milligrams of phenobarbital is equivalent to 1 milligram of Klonopin, equivalent to 1 milligram of Xanax, 1 milligram of Ativan, 10 milligrams of Valium, and even Soma. Soma is a muscle relaxant that's addicting, and we'll take patients off of Soma by using phenobarbital. When you give too much phenobarbital, you'll get the eyes will be kind of off kilter. They'll be jumping back and forth. That's called nystagmus. They'll get ataxia. They'll be walking like they're drunk. They'll get a slurred speech. So what we do is we get them on a stable dose for 2 days, and then we put them on a tapering schedule. The thing with phenobarbital tapering is you got to go slow. Frequently, people have been tapered off too quickly, and they'll go back into withdrawal. Sometimes it might take months to get people off of it, in which case I would see them in my practice afterwards and gradually reduce the dose, and that works well. You can expect some reemergence of some mild withdrawal symptoms when you get them off 5 to 7 days after each decrease in dose. And occasionally people will have trouble getting off of the benzos themselves. So then we can use anticonvulsants. This is what would be called a second-line treatment to get people off of the benzos. These are the anticonvulsants that can be used. Gabapentin has been used for benzo withdrawal. You might need a high dose up to 1,200 milligrams per day. Trileptal has been used, 150 to 300 milligrams at bedtime or twice a day. Lyrica has been used, 75 milligrams every bedtime up to 3 times a day. Depakote has been used, valproic acid, 250 milligrams 3 times a day. And carbamazepine is a medication, Tegretol, that's been used too. And then we can use other medications to get people off while they're going through this by giving them hydroxyzine, which is an antihistamine for anxiety. Propranolol slows your heart rate down, and trazodone for sleep. And that is all I have on the benzos. So now I can open up to any questions on either the opiates or the benzos. Yes? And I'll repeat the question for you. Yep. Yeah, the question is the doctor's responsibility in all this opioid epidemic, and it's big, yeah. And I've been around long enough that when I was first starting out, we were told as a doctor, never prescribe opiates for chronic pain. Only for a sprained ankle, mainly for surgery, but never for back pain or arthritis or anything that might go on. And then it went into the 1990s and early 2000s, and doctors were told, you're letting patients suffer. Our goal is to relieve suffering. You can't be afraid of these drugs. They're harmless. And this kind of came from the pharmaceutical companies too. They were pushing these drugs. Give them more. You can't really have your patients suffer. If they're suffering, you should ask every single patient how much pain they have on a scale of 1 to 10, and if it's a certain one, you got to give them drugs. So then doctors went the other way. Doctors were even losing their license for not treating pain, not giving enough medication. So the doctors started to give a whole bunch of it, and now it's back the other way, where doctors are giving it for anybody with back pain is getting 200 milligrams of OxyContin a day. So that's where it goes out. Most of the young people that get addicted to heroin, they started out by getting oxycodone or OxyContin out of their parents' medicine cabinet. So the question is doctors' responsibility, and it's big, and doctors are now being re-educated on this.
I have a question about the naltrexone.
Yep.
I know it's not so crazy, but say if someone did use while they were on it and they use more, or they say that they used to use more and more, do they overdose?
The question is the naltrexone, and if you use like heroin or an opiate, when you've got the naltrexone in your system, no, they don't overdose. The heroin just wouldn't be effective. It wouldn't bind to the receptor. There'd be no effect. It would be like injecting water or snorting a cigarette or whatever. There just wouldn't be any effect. The problem, so theoretically, if somebody had an unlimited supply of heroin and just kept shooting it and shooting it and shooting it, I would guess there's a point where they've got so much heroin in their system that then they would overdose. The problem is when they stop using the naltrexone, their tolerance is down. If they relapse, that's when they overdose. Yes?
I'm here for my addiction to diazepam, and what I'm curious about is I've had seizures for like since 8th grade, and I was always on Tegretol medication, and now I'm on a phenobarb taper, and I know that that also is a anticonvulsant. So when you're saying that they also use Tegretol to help with that, so in conjunction, so I'm guessing that with the two like that, then what I heard you say was that it will, the phenobarb, there will be no extra withdrawal from that. That also is a higher medication, correct?
Questions about phenobarbital used for benzo addiction, and is it phenobarbital addicting? You know, it's a barbiturate, but it's so long acting. I've never ever seen anybody who's got addicted to phenobarb. The phenobarb was their drug of choice. They just don't like it that much. So usually you get the right dose, so you're good at it, and then when you taper down, it goes really well. It's not like tapering Suboxone or tapering methadone or tapering a lot of things. Phenobarb taper goes really well. The Tegretol, the question also is about Tegretol. I've had people that I use phenobarbital for, and they're still kind of having some anxiety and some symptoms of withdrawal. you can add Tegretol on top of that. And Tegretol can be used for a long, long time. It's not an addicting medication. Yes?
I actually had two questions, one kind of general, one specific. On the general one, are the different brain chemicals like serotonin and dopamine, are they actually measurable in one's brain?
The question is brain chemicals, neurochemicals like serotonin and dopamine measurable they're measurable in the blood, but they're not measurable in the brain, and the brain is where it matters. So you'd have to stick little tiny needles in the brain, and nobody does that. So no, you can't measure dopamine levels and serotonin levels. So a lot of the information about dopamine and serotonin and the antidepressants is guesswork. You know, you give a medication that increases brain serotonin and they feel better. People just assume that it's because of the serotonin. So.
And the second question, real quickly, I think you already touched on it about doctors' responsibility in this epidemic. What would you say about a doctor that prescribed Ativan for a solid year?
The question is, what would I say about a doctor that prescribed Ativan for a solid year? Chronic long-term benzo use has its problems and risks, certainly. So if somebody has the disease of addiction and got a benzo for a year, that would be a problem. But you can't, in any individual case, you know, you got to know the case. So I can't sit here and say that this doctor in this case shouldn't have done that. In general, benzos are a problem. They're very addicting. Long-term benzo is worse. Benzos in addicts is even worse. So I can make general statements, but not specific statements. Yes?
Do you have any, are there any side effects when you stop using naltrexone?
Question is, are there side effects when you stop using naltrexone? No.
Not at all.
No withdrawal from it. Zero. Yes?
Are there any other drugs, like, let's say I broke my leg or something, went to the hospital, and rather than giving me an opiate, is there something other that's like as strong or something like that that would...
Yeah, question is, if you're on an opiate blocker, naltrexone, and you go to the emergency room with a broken leg, what are they going to do, right? Yeah, there are things they can do. Emergency rooms can handle that situation without a problem. There's Toradol, which is a anti-inflammatory medication that can be given IV or intramuscularly, and it's as strong as morphine, actually, in terms of pain control. They can do regional blocks. If your leg is broken, they can block the leg. They can do Novocaine-like pain medication. They can do sedative. They can put you to sleep. So there's lots of alternatives. Yes?
Chronic pain. Suboxone. Does it help with chronic pain? Because as I came through, I realized my pain is coming back. And I thought maybe it was gone when I first started.
You know, the question is Suboxone for chronic pain. So when I started out prescribing Suboxone for addiction, some of my patients became addicted because they have chronic pain. And so I started seeing them, giving them the Suboxone for their addiction, and their pain was much better. They went on with their life, and their pain was well controlled. Then pain specialists started to learn about this from the addiction specialists, which I am, and so pain doctors are interested in it. And yes, Suboxone is a very good long-term chronic pain medication. It does relieve pain. And some pain specialists are now using it even when there is no addiction. But it is an opiate. It stimulates the opiate receptor, so it has all the problems that you got to watch. You got to have monthly visits. You got to do urine drug screens. You got to wean people off. You got to watch. You don't see the escalating dose with Suboxone for chronic pain. I've had, when people get OxyContin for pain, for example, they'll start at 40 and then they're 80 and then they're 160. Suboxone, they tend to just stay at the same level. So it's a very good medication for chronic pain. Any other questions? Yes?
Has there been any studies done regarding addiction and post-gastric bypass patients?
Question is addiction and post-gastric bypass patients. Yes, there have been some research done, mostly with alcohol and gastric bypass. When you have the gastric bypass, that's going to affect your absorption of the alcohol, affect how fast it hits you. But there's even some theories that maybe just altering the anatomy with the gastric bypass even affects it even more. It may even affect brain chemicals. So yes, there is an increased risk of certainly alcohol dependence in somebody that has had a gastric bypass and maybe other addictions also.
And they follow up, do those medications, how do those medications help patients that have gastric bypass?
Which medications?
Oh, I'm curious about naltrexone and
Yeah, I don't know if that's a great question. The question is the medications used for alcohol dependence in a gastric bypass patient. And I'm not sure of a study that's taken gastric bypass patients and looked at the naltrexone. Naltrexone is used for alcohol dependence, but is it better in the gastric bypass patient than in the non one? I don't know. That's a good question. Yes.
When I was treated in 2004, I got the treatment for 13 months of mainly opiates and then, Tylenol. They had me in a hospital. I went to the and they give me 8 pain pills without being complicated for it. And I was healed. I was really, give me a stable.
So
I'm asking, why would a treatment center do that?
why would they do what? Like, I didn't.
They take it all of, like, your one treatment center, this is, give it a lot of it. That was in 2004.
Yeah, I think the question was you were on a lot of medications and they weren't tapered, they were just stopped. Yeah, that's not good. Most medications, particularly the ones that cause withdrawal, need to be tapered rather than stopped.
She went to a treatment center though, and she said that they didn't taper her up anything, she just had to do cold surgery basically in the treatment center.
I would strongly disagree with that treatment center, yeah. Yeah. Yeah, I'm not sure why that happened to you. Yeah, tapering is better. Yes.
Now, I know that naltrexone blocks the effect of the opiates.
Right.
Does it do the same for alcohol?
The question is naltrexone for alcohol dependence, and it blocks. All it does is it blocks the opiate receptors. But then there was a theory that alcohol addiction involves dopamine, and dopamine is connected to the endorphins, and the endorphins are connected to our opiate receptors. So maybe there's not alcohol dependence and